Welcome to another episode of Virus Decode, a show where the print team and health experts, all of us get together to decode the causes, impact, and preparedness to tackle this virus in India for you. The issue that we'll be focusing on today is long COVID. How can we manage it, and what are the key risk factors? And for this discussion today, we have a fantastic panel. We have with us Dr. Lancelot Pinto, who's a consultant pulmonologist and epidemiologist at Mumbai-based PD Hinduja Hospital, Dr. Om Srivastava, infectious disease expert and a member of Maharashtra COVID Task Force, and our in-house expert, Simran Surur, who will answer all your questions and decode this virus for you. A big thank you to all our panelists for taking out the time and joining us today.
Thank you.
Reminding our viewers here that we will be taking audience questions. So do send us your questions and over the next 30-35 minutes, comment in the chat box and my team will send your questions to me and I will make sure that I put as many as possible to our experts here. Now, before the audience, I take up audience questions, let me just begin with Dr. Pinto here. Now, Dr. Pinto, we know that the first case of COVID-19 in India was reported in January 2020. And since then, most of the resources and planning has focused on restricting the spread of the disease and treating patients. But now we are realizing that a parallel long COVID is emerging. That's our focus of discussion here. Can you tell our viewers a little bit about what we know about long COVID so far and its clinical manifestations as well?
Hi, Apurva. Thank you for inviting me to the show. I think there are two things that happen as a result of COVID. One is what we call the sequelae of infection, right? If you have a severe infection that involves the lung, for example, you might have a few scars left in your lung, and that is just what we call a sequela. That's scarred tissue causing problems in the long run. And then you have long COVID, which really doesn't fit in that category. It's not just a consequence of severe disease, but it's this bunch of symptoms which may not overtly reflect what happened to you during the course of COVID. So your COVID might have involved a cough, for example. Your COVID might have involved having a fever for some time. But there are these symptoms, and unfortunately, there's a whole gamut of symptoms which has been described, some of which are this extreme fatigue, which has also been called brain fog by some people, this fatigue and being inability to think clearly. To an extent that it cripples some people. So, if you've listened to testimonials given by people with long COVID, and some of which we've heard in our clinics as well, just the simple acts of writing a letter, simple acts of sending an email, simple day-to-day activities feel like a challenge, feel very overwhelming. So that's the brain fog, the fatigue part of it. There's lots of aches and pains. Chest pain is a very common symptom described by a lot of individuals. This feeling of tightness in the chest, the feeling that you can't breathe completely, the feeling that it's incomplete, your breath. Aches and pains throughout the body have been described. There have been gut abnormalities described. So people talk about how their gut has not settled down in different ways. So some people have diarrhea, some people have bloating that they've described. So I think these are some of the broad symptoms that come up again and again. In addition, we knew that with Delta, there was a loss of smell and taste, which was there in some individuals, that persisted for a long time as well. So these are some of the common symptoms. Now, why these occur is still a mystery, and there are different hypotheses that have been postulated. One of which is that there is some residual virus still in the body. The body has not cleared out virus. So the body's immune system is constantly mounting a fight against that virus. So, the temperature fluctuations that have been described as well have been attributed to this, suddenly feeling cold, suddenly mounting a fever for no reason. The other is autoimmunity. So the virus triggers some sort of a response in the immune system where the immune system starts attacking its own body, which is what we call autoimmune diseases. There is a new theory, which is, there's a new study which has spoken about how the microbiome of the gut. So normally all of us have different microbes in the gut which maintain a healthy gut, and that gets disturbed by COVID as well. And some of the autonomic dysfunction has been attributed. So the autonomic system is a system that regulates the temperature in the body, regulates blood pressure, regulates heart rate. And that also goes out of whack with COVID very often. So sudden drops in blood pressure, sudden fluctuations in heart rate, suddenly sweating, suddenly feeling cold. This is part of the autonomic nervous system. There's something called POTS, which has been described, which is postural orthostatic tachycardia syndrome. I think that's what it's called. So this is the whole gamut which has been described, and we're not really sure what's driving some of it. So, I mean, in a nutshell, that's what long COVID is all about.
Dr. Pinto, before I move to Dr. Srivastava, actually, since you mentioned brain fog, right before this show, Simran and I were discussing it. We were sort of curious. So, if you could briefly, for our viewers as well, tell us what exactly happens in brain fog. Do you know what can this be attributed to?
So a lot of studies have now, I mean, the higher end, the high tech studies have looked at subtle things, right? So there have been studies that have looked at the distribution of gray matter and white matter in the brain using MRI techniques before and after COVID. And there are some suggestions that something happens in the brain at a subtle level, which clearly shows up on an MRI. So for those individuals who think that it's just being imagined, or it's just psychological, or it's just a psychiatric manifestation of disease, there are actually imaging studies that have clearly shown abnormalities in the brain before and after COVID, and possibly some of that contributes to the brain fog. Same thing with the chest. There is something called xenon imaging which is being done, where they send a radioactive tracer into the lungs. You breathe into it, and it sees how it spreads through the lung. And they found that at a microscopic level, at the distal periphery of the lung, there are still abnormalities in how oxygen gets diffused across, and that possibly causes this tightness of the chest, this shortness of breath, which will not get reflected with crude tests. You need like finesse, you need microscopic tests to pick that up. So the brain fog is basically this inability to compute, the inability to think clearly, the inability to do anything that takes more than a bare minimum, and possibly is related to these microscopic changes. And a lot of COVID has been attributed to the blood vessel system of the body, or the vascular system of the body. So it is hypothetically possible that the virus, in some way, because of the inflammation, causes small little clots in different parts of the body, tiny microscopic clots, and maybe that's what's causing some of this brain fog as well. So I mean, we don't know the answer to that question, but this is what the hypothesis is right now.
Okay, that's very interesting. Coming to Dr. Srivastav now just as there are shades of severity when it comes to COVID-19 infections, is there, according to you, is there a similar gradient among patients suffering from long COVID as well?
Yeah. So first of all, thank you for having me on your show. There are grades of severity. There are those people who will, after the infection, who will probably be unwell for no more than maybe a couple of weeks, maybe even less. And then there are those sets of patients who have been unwell, say even after the first wave, they've been unwell for about good 8-10 months, 1 year's time. This is persistent. It does not apply to any one particular gender or a particular age group. There are very very fit people in their 80s who are having the sequelae of COVID, and there are people who are in their 20s and 30s who are also having sequelae, and they're not able to shake it off. So it's a little difficult to say. There is also, besides all the points that Dr. Pinto has mentioned, there's also a fair amount of work that has gone on to one part of your cell, which is called the mitochondria, which is pretty much the energy storehouse. This is the part which will decide how energetic you are going to be feeling when you start your day, or when you're going through the paces of the day. There is some amount of evidence that the mitochondria is damaged, and in some parts irreversibly. So it will go through a whole cycle of changes. Until that happens, people will be feeling the effects of not just exhaustion, fatigue, and brain fog, but also having several organs that are going to be impaired for a very long period of time. Seeing that quite frequently, not just with the not just with lungs and brain and gut, but also with things like sexual functions, marital life. All of those things get impaired and remain impaired for a long period of time. And people have this kind of a sequelae that impacts not one but two, maybe three or four systems. So yes, there are people who are trying to make a clean breast out of it, but not always happening. And that's something that we are learning to deal with in a vast majority of patients who have recovered from COVID more than 6 months ago.
Of course. Now, since you mentioned that there's a varied degree of manifestation when it comes to long COVID, have you noticed any pattern whatsoever so far? How common is it in COVID patients?
So there are those people whose systems are inherently inflamed. All right,
Okay.
they're people who've got either a particular kind of a lifestyle, or a particular kind of underlying disorder that will make it difficult for a system to be settled down. That means you're either smoking excessively or drinking excessively, or you're doing 16 hours a day. You're burning both ends of the candle, or you've got an underlying disease which is, say, like a malignancy or a steroid dependent condition. In all of these situations where your own immune system is not quite at rest as it should be for your age, these people tend to be having the larger manifestations for the longer period of time. Of course, that is the vast majority, but not the entire picture. There are those people who've got very well settled immune systems. Of course, there are ways to measure that. You can quantify that. But in spite of the fact that you might meet somebody whose immune system parameters are very, very good, they are still going through a lot of troubles, not just with exhaustion and fatigue, but with other system involvements.
Okay, we have quite a few viewer questions coming in, but before I start taking them, just coming to you, Simran, here for a minute. Now, you've covered the pandemic ever since it began in the country. When we speak of long COVID, do we know what causes long COVID? If you could tell our viewers a little bit about this.
So we don't know what causes it, and Dr. Srivastava and Dr. Pinto would be in a better position to talk about that. But there is new research coming in that offers clues about who might develop long COVID and who might not. So there is research by American scientists who found that there are 4 risk factors that can make a patient more prone to long COVID. And I'm happy to walk you through those, viewers through those. So one of them is something that Dr. Pinto had mentioned, which is the presence of auto antibodies. There's the presence of type 2 diabetes, patients who had a high viral load at the time of infection, and also the reactivation of the Epstein-Barr virus, which is, it's a common herpes virus, also known as mono. So they found, these researchers basically tracked 209 patients and for a period of 3 months. And what they found is that a majority of them, a little over 61% of these patients, had at least one of 20 post-COVID symptoms. And 37% of those patients had 3 or more of those 20 symptoms that they were tracking. And a majority of those patients who had reported 3 or more of these symptoms also had one of these 4 factors that made them more at risk. And this study was also, they also looked at a batch of patients who had mild COVID, and they found that, these risk factors were true in that case too, across, patients who had severe COVID as well as mild COVID. So this is what we know now about what factors can play a role in who will develop long COVID and who won't. But having said that, I have a follow-up question for Dr. Pinto about these auto antibodies. How do they work, and how is it different from an autoimmune disease? How does the action of the auto antibody differ from, say, having an autoimmune disease? And do patients who have these auto antibodies, do they suffer from autoimmune diseases or no?
My understanding, again, I'm not a rheumatologist or an immunologist, but my understanding is that we haven't identified a particular autoantibody. The presumption is that the virus or the viral fragments set off your immune system in some way, and then that immune system which has been set off, or maybe there are some persistent viral fragments which set off that immune system, cause then your own immunity to attack your cells, and that's what autoimmunity is all about. Now, I think this hypothesis also comes from the observation that studies have been done in diseases like multiple sclerosis, for example, which have postulated that there is a viral etiology there, which is why if you look at the distribution of multiple sclerosis, it seems to be more in the colder countries of the world than the warmer countries. And that's been hypothesized to be associated with viruses. Then there are other diseases such as fibromyalgia, which again follow a similar, there have been patterns which have been observed that when there's a viral infection in the community, there is then post the viral infection and increase in the rate of fibromyalgia in certain communities. And these are observational studies which have been seen in the past. I think that's where the hypothesis comes from. Now, to the best of my knowledge, we haven't identified a particular autoantibody that you can check in your blood and say, oh, yes, this explains your long COVID. But I think what's interesting is if we do find some sort of a correlation there, then medication that works on the immunity or works on autoimmunity, which would be some sort of immune suppressive medication, which would be medications that we use say for diseases like rheumatoid arthritis or SLE or other kinds of diseases which have been attributed to autoimmunity. That's where maybe the focus will shift onto in terms of treatment of long COVID, versus just assuming that this is something that needs counseling, something that needs just rehab.
All right, for our viewers, the study that Simran was talking about, we have an article on the print on this, and I'll make sure that the article link gets added to the description so that you can go ahead and read it in case you're interested in doing that. We have an audience, a viewer question coming in right now from Harman. If Dr. Srivastava could take this. Harman is asking, can we say contracting COVID triggers a growth of certain diseases in our body that we would have otherwise fought as usual?
Quite possibly. Quite possibly. We are actually at the infancy of understanding what COVID is going to do. Remember, it's a condition that we have seen for less than 2 years or just about 2 years at this time. We know for sure that various organs get affected in various ways. As to where is this going to stop, I don't know. I don't think that we know that as yet. But yes, you could go through an entire lifetime, certainly in terms of infectious diseases, which is my practice, and immunology, which is also my practice. You could go through an entire lifetime of having several conditions which are hibernating in your system. If you are having, like I've been saying earlier, if you're having an immune system which is otherwise robust, you probably won't even notice that you may have carried on this particular predisposition to a particular kind of disease sets, and that may get provoked with a number of factors. One of them is, well, an infection like COVID.
Okay, that's very concerning, but I'm sure Harman found that answer helpful. We have another question coming in for Dr. Pinto. This is Rudraksh asking, how do we identify we have brain fog, and is this a disease that needs medical attention?
Again, a couple of caveats. I think we still need to emphasize the fact that long COVID is not extremely common. The reason it becomes common is because the denominator is so large. When you have the entire population being infected within a span of 2 years, even something that's very uncommon will still multiply into huge numbers, right? So a significant proportion of the population, as Dr. Om has also pointed out, will have fatigue for a couple of weeks, maybe a month, but will gradually recover to normalcy. So it's a small fraction in which in whom the symptoms persist for a really long time. So how would you know if you have brain fog? I think when you listen to testimonials of those who do have it, it doesn't sound like a confusing condition. It's pretty much black and white. Those who have it will tell you that before COVID, they had a certain level of functioning which was very clearly at a certain level, and post COVID, sometimes for months after that, they haven't quite gotten there. And I think so. There is not much ambiguity among those who've experienced it. If you're very ambiguous about it, maybe you don't have it, or maybe it's a very subtle version of it, which doesn't need anything further. Now, of course, if you do have it, in terms of what investigations, I think it would always be a good idea to see a physician, simply because it may not only be long COVID, there may be something else going on. You need to make sure that you've ruled out everything else. Your sugars can go up in COVID, for example. Make sure that that's not causing a problem. Make sure your vitamin levels are adequate. Make sure all the check marks have kind of, all the checklist has been gone through. And then if you do have long COVID, enroll yourself in some sort of a study if you have access to that. And, see somebody who's, I think most of us physicians try to keep ourselves updated on what's coming out. And if some obvious new treatment comes out, of course, you would be eligible for that. As of now, no. To answer that question, as of now, I don't think there's any specific treatment, but I would still encourage you to see a physician to make sure nothing else is going on.
Of course. Now we have another question coming in from Devinder Singh. Either of you can take this question. He's saying, I was found COVID positive on 14 Jan. My X-ray was done after a week and all blood tests were okay. Fever was for 17 days, but no fever for the last 5 days. But he says he's still positive. Now his question is do you think is that the dead virus in his body?
So, I mean, if it's an RT-PCR, we normally don't even recommend doing an RT-PCR at the end of treatment, simply because we know that RT-PCRs can remain positive for sometimes up to 2 months. We wouldn't focus on the positivity of the RT-PCR as being a surrogate. Because like the person rightly pointed out, it could be dead virus which is in the which is still harbored in the throat. Another point I need to clarify from what I said earlier, in terms of what can be done. There are studies which do suggest that vaccination makes a difference to long COVID. That a significant proportion of individuals who haven't been vaccinated, had COVID, had long COVID, then have the vaccine, and some of the symptoms do go away. So one of the messages that should go across is, number one, please do get vaccinated if you haven't been already. Long COVID is another reason why you want to not get COVID. And second is, if you've had COVID, you're experiencing long COVID, but you haven't been vaccinated, this is the time to go ahead and get vaccinated.
That's a very important message for all our viewers right there. For Dr. Srivastava, another question that we're getting is, how can doctors discern, or how can people discern symptoms of long COVID from other illnesses?
That's a gray zone. How can you discern symptoms of long COVID from other illnesses? Most illnesses will have some telltale signs. When you see a doctor, you go to a doctor and you say, look, this is what I feel is wrong with me. Long COVID is not yet a clearly defined clinical entity. It's more a diagnosis of exclusion. When you say I've got headaches, or I've got blurring of vision, or I've got fatigability, your doctor will going through the investigations that are required to make sure that those things are ruled out. Once all the reasons of these kind of symptoms are ruled out, then you start to entertain the possibility of a condition like long COVID. So long COVID comes more as a diagnosis of exclusion rather than a primary diagnosis. And that's what your physician should be approaching it in that way, and telling you, look, there's nothing else which is wrong with you. You seem to fit the broad boundaries of somebody who's got a persistently inflamed system, and perhaps you're dealing with a long COVID syndrome, right?
Of course, we have another question coming in for you, Dr. Srivastava, where Kritika Singh is asking, how long does long COVID last? Days, months, or years? She's clearly concerned. So if you could, tell her if there's any data on this so far.
The first thing is, we don't know how long it is going to be present. Second thing is, we don't know how are you going to be making a diagnosis that you no longer have long COVID. And that the only thing that you can probably ensure is to have a good rehabilitative program to help you come out of whatever symptoms that you're going through. Seek professional help. Try not to self-medicate. Make sure that the medication that you take are under supervision. Other than that, you simply have to try and get to be at the peak fitness for whatever age you are in, and that ensure that if there are any residues of your COVID infection that is coming out of your system, simply because you're eating well, you're sleeping well, you're exercising well.
Okay, I think here you're talking about the way forward too. If Dr. Pinto, you could also talk a bit about what is the way forward from here, and what sort of things people can do to sort of manage long COVID.
I think, nobody denies the fact that this is clearly an entity which is defined, and it's, there are manifestations of it. But one must also remember that in parallel, there are lots of other things that could also cause fatigue. For example, low vitamin D3 levels have been associated with fatigue, and this is the time to supplement it if your levels are low. In Indians, B12 levels can very often be low, and that causes a lot of neurological symptoms as well. So this is the time to check that if you're experiencing symptoms. A high protein diet is very often recommended in recovery for any disease, and maybe this is the time to make sure that you're eating a good, nutritious, balanced diet, you're sleeping well. And of course, the past 2 years have been challenging mentally for every single person. So when I say that you might have mental health issues associated with it, I'm not dismissive of your long COVID symptoms. But if there are in parallel mental health issues as well, it may not be a bad idea to seek help to make sure that those are addressed as well. So that we try and optimize everything else while we try to learn more about this disease, and we try to figure out a cure. So rest, hydration, nutrition, making sure that you're reasonably physically active. If you've had bad COVID, in terms of if you were in the ICU, for example, if you were on a ventilator, getting physical rehabilitation is extremely important because that will help build up your strength again. And I think basically going through making sure that everything else is optimized, so that at least everything else is optimized while we wait and try to figure out what the right treatment is the way forward, is what I would think.
Just moving away from the medical aspect of it to policy changes, Dr. Srivastava, since you are also a part of the Maharashtra COVID-19 task force, do you think there need to be any policy changes to deal with long COVID as well? And do you think there is sufficient focus on ground on long COVID? Is there sufficient debate, do you think?
Well, a number of institutes, both public and private institutes, have already invested in having, like a COVID OPD. That means you may have recovered from COVID, but you still can come and see somebody who's sitting on the desk of that OPD, outpatients, and you could talk to them about what's going on with you. What will need to be done is, and this is something that we have discussed at length at the task force, is that you probably need to collate the data that has come out in the last 2 years' time as to which kind of people, which populations, which selective groups of people had the longest kind of problems, and what made the biggest difference in their quality of life over a period of time. Once we get that kind of a process in place, then it'll be easier, it'll be more productive, it'll be more incisive to be able to start a program which says that, look, for a person with this kind of illnesses, this kind of therapy is what's required, and this is how we should monitor that these people will be coming out or not coming. So I think that there is a need to make it more streamlined, more centralized, but that's a work in progress at this time.
Of course. We have another question coming in from Avneet. Avneet is asking, do people get long COVID, post-COVID complications based on the amount of virus they're exposed to? Avneet, we did discuss, Avneet is talking about the causes, but if either of you could, answer this briefly.
So we're not actually quantifying viral loads in COVID, which we ought to be doing. We should have been doing it. I'm not aware of any center anywhere that has quantified consistently a viral load for COVID, because we are more concerned about number of other aspects. But that would be a very important assessment to find out what was the viral load and what was the outcome, say 2 weeks, 1 month, 2 months, 3 months, 6 months, or 1 year after you recovered from COVID. That would give you an idea as to how aggressive is the virus. For instance, the virus in its first avatar, in the first wave, is very different to the one that you're dealing with right now, Omicron. But in between these two, there have been the Delta waves, the Delta plus, the Gamma, Thetas, all of them have had various kind of viral presentations, and therefore they're going to be having, so it's viral loads are inconsistent in patients who are probably going to be attracting a certain kind of viral replication that is going to be higher. That is different from patients who may not be having the same kind of replicative virus in their system. So I think that, yes, it's a very good question. It would be very useful to get a quantified viral load. Unfortunately, we're not doing that, except for very small selected groups of people who are mostly in tertiary referral research institutes all over the world.
Of course. With this, we have
Purva, can I get a button to ask a question?
Of course.
So, about viral load, can you tell us a little bit more about how viral load can be quantified? Because there was a big confusion during COVID testing about something called the CT value, and whether the CT value is actually representative of how much virus is in you or in the sample that was taken, and whether it correlates with how severe the disease is. So can you walk us through also how the viral load can be quantified, and whether CT value plays any significant role at all?
So CT values to start with were considered to be very important. CT values are pretty much only reflective of one thing. What is the total amount of colonization of the virus in your nose at the time the nose swab is inserted and that sample is taken? That is not reflective of the virus elsewhere, from your nose to your throat to your lungs to the base of your lungs. Viruses tend to be, this is an RNA virus. It's a tiny virus. It's also a mischievous virus. If you look at all the other viruses in this family, they're all mischievous. They're all capable of being elusive.
Dr. Srivastava, you'd have to unmute yourself.
Sorry about that. They're also, difficult to, they're smaller viruses, so they're able to move in different directions at different points. So CT values are not reflective of what is your viral load at any one point in time. They're only reflective of the fact that at that point in your nose, when the swab was inserted, what was the quantification of the virus at that time? How do you quantify it? Yes, there are several. Say for instance, when you do an RT-PCR, most laboratories will have a cutoff that if you have a certain number of copies of a virus, for most laboratories, that threshold is about 380 copies. When you do a gene expert on that sample, that cutoff is about 500 copies. That is an indirect way of saying that the total number of copies in this sample were in this range. That's also not the most reflective, but it is close to being the most accurate kind of assessment. Viral loads can be measured for a number of viral infections, but for that you need to have a standardization of a laboratory. You need to have a standardization of equipment so that your readings are not inaccurate, and that is how you are going to be able to say. For instance, let me give you another example. When suppose you are dealing with the H1N1 virus, all right, the H1N1 virus will start to disappear in one single dose of one of the treatments that is used, oseltamivir. And so viral loads have to be very specifically used before you start your treatment immediately. So it's a little tricky to say this is how I'm going to quantify this patient's viral load. But again, I come back to the point: in smaller viruses, it may be difficult, but it still needs to be done.
Of course, that's very helpful. Now, with this, we've reached the end of today's discussion. A big thank you to all our panelists for taking out the time and joining us today, and for our viewers. We hope you enjoyed this discussion. Do let us know in the comments section